In this video, we'll discuss respiratory acidosis, carbon dioxide reaction, and the causes of respiratory acidosis. What's the normal PCO2 in the air, arterial, and venous blood? In the air, PCO2 is 0. In the arterial blood, PCO2 is 40 millimeters of mercury with a range of 35 to 45 millimeters of mercury. And in the venous blood, PCO2 is 44 millimeters of mercury. And how much is PCO2 in respiratory acidosis? In respiratory acidosis, PCO2 is more than 45 millimeters of mercury. It's known as hypercarbia. It may be acute or chronic respiratory acidosis. Acute respiratory acidosis occurs in less than 24 hours and bicarbonate increases by up to 0.1 milliequivalent per liter for every millimeters of mercury rise in carbon dioxide. Chronic respiratory acidosis occurs in more than 24 hours and bicarbonate increases by up to 0.4 milliequivalent per liter for every millimeters of mercury rise in carbon dioxide. What parameters are increased or decreased due to respiratory acidosis? In respiratory acidosis, there are increased carbon dioxide, increased hydrogen ion, and increased bicarbonate, and a decrease in pH. The normal pH being 7.4 with a range of 7.35 to 7.45. Why bicarbonates are increased? Bicarbonates are increased because of the compensatory metabolic alkalosis with a bicarbonate levels of more than 30 milliequivalents per liter. The normal bicarbonate range is between 21 to 24 milliequivalent per liter. Bicarbonate can increase to a maximum of 45 millimeters of mercury in respiratory acidosis. A bicarbonate level of more than 45 millimeters of mercury indicates coexisting metabolic alkalosis. And how about the pH? Normal pH is 7.4 with a range of 7.35 to 7.45. A pH of less than 7.2 impairs the cardiac contractility. So what are the causes of increased carbon dioxide retention? Number 1, increased production of carbon dioxide, decreased removal of carbon dioxide, or decreased alveolar ventilation. Causes are COPD, fever, infection and seizures, and fibrosis of the lung, for example silicosis. Number 2, disorders causing respiratory muscle weakness, Guillain-Barré syndrome, poliomyelitis, and multiple sclerosis. Number 3, depression of the medullary respiratory center, head trauma, opiates and sedatives and anesthetics may cause depression of the medullary respiratory center. Number 4, disorders of the chest, scoliosis, kyphoscoliosis, and pneumothorax. Number 5, airway obstruction, and number 6, increased carbon dioxide in the alveolar air. Also, neuromuscular blocking drug, acute cardiac arrest, strokes, status epilepticus, and cervical cord injury may cause respiratory acidosis. What's the effect of increased alveolar PCO2? When alveolar PCO2 is more than 7%, arterial PCO2 rises abruptly despite ventilation and produces hypercarbia, causing carbon dioxide narcosis. What's the difference in respiratory acidosis in COPD with vomiting and COPD with diarrhea? COPD with vomiting causes respiratory acidosis with metabolic alkalosis because in vomiting there is loss of hydrogen ion, whereas COPD with diarrhea causes respiratory acidosis with metabolic acidosis. And what are the clinical features of respiratory acidosis? Rapid shallow breathing, disorientation, hyperreflexia, dysrhythmia, decreased cardiac contractility, headache, anxiety, blurred vision, restlessness, tremors, delirium. There is vasodilatation in the cerebral blood vessels causing increased CSF production that leads to increased intracranial pressure and papilledema. In which organ system increased carbon dioxide causes vasoconstriction? Increased carbon dioxide causes vasoconstriction in pulmonary blood vessels.